two cases in which I was guided the whole procedure. No conflict of interest. So the first case is I was guided LMCA bifurcation, modified DK crush of the LMCA bifurcation. Stories of a 63-year-old hypertensive, non-ST elevation MI, normal LV function, had critical LMCA plus double vessel disease, not willing for surgery, taken up for PCI. So right coronary artery was dominant and normal. LMCA bifurcation had a Medina 111, with significant tight lesion in a left circumflex, which is of more than 3 mm vessel, extending more than 10 mm into the circumflex. There's also a tandem lesion in the mid circumflex and the distal LAD. So by definition criteria, this is a complex LMCA bifurcation and needs 2-stent strategy. So the plan was to do an IVUS guided DK crush. Since it's a complex LMCA bifurcation, we do the initial hemodynamics, all look favorable, so no need for backup MCS in this scenario. We go from the right femoral axis, get wires down both the vessels, get a pre-dilatation just to facilitate a good good IVUS imaging assessment. We first IVUS the LCX after pre-dilatation 2.25 balloon. So we understand that the morphology, it's a more of a fibrofatty plaque. The distal LCX is about 3.5 referenced. The length of the lesion was about 30 mm till the ostium. The ostial LCX has almost 80% plaque, clearly meaning that it requires a 2-stent strategy. And the LMCA from the LCX pullback is about 4.6, and the mid LCX lesion had an attenuated plaque. We have an IVUS run on the distal LAD after the initial pre-dilatation. We find that still the MLA is about 1.6 only after the initial pre-dilatation, and there's some amount of dissection also in the distal LAD. So the initial strategy of doing a DEB in the distal LAD goes off after the IVUS. So the reference diameter proximal to the lesion is 2.7 and distal is 2.6, and the lesion length was 16 on the IVUS run. We do the third IVUS from the proximal LAD to the LMCA. Again shows a predominantly fibrocalcific plaque. The ostial LAD, the MLA is about 1.9. Each of these parts have been bookmarked. And the plaque burden in the ostium of LAD is almost 83%. So in the middle LAD, the normal healthy zone, the reference diameter is about 3.4, and the LMCA is almost 5.0 in the on the IVUS. So we clearly need a stent like Megatron, which can actually go up on 3.5 on one side and more than almost 5 on one other side. Megatron can go up to 6. So Megatron becomes a suitable stent based on the IVUS strategy, and the bifurcation angle is about 80. So we complete all the formalities. The distal LAD dissection is stented with a 2.516 and post-dilated 2.75 non-compliant balloon at 18 atmospheres. After the distal LAD is settled up, we go and work on the LMCA bifurcation. The ostial LAD and the osteoproximal LCX is pre-dilated 312 non-compliant balloon. They yield with no residual waste. We place a synergy 3.532 from LMCA to LCX with about 3 mm protruding into LMCA, keeping a 3.5 non-compliant balloon in the LM to LAD to crush the stent. The stent is deployed at 11 atmospheres. The stent balloon is pulled and dilated at 18 atmospheres, what constitutes as the first proximal side branch optimization. And this step actually makes the side branch crossing easier subsequently. The LCX is checked for distal dissection. The LCX wire is removed, and then we do a step crush. The distal part of the stent is actually crushed with a 3.5 non-compliant balloon, reference to the LAD diameter, and the proximal crush is done with a 4.5 non-compliant balloon, reference to the LMCA diameter. Again, all these are obtained from IVUS. The first cross again is actually through the proximal struts. We cross-check on the stent boost, and the IVUS also confirms that there is actually adequate stent crush and the proximal cross of the wire. Subsequently, the LCX struts are actually opened up with a 2.0 non-compliant balloon. And the first case is done with 3.5 balloon in the LCX and 3.5 balloon in the LAD, each sequentially at 18 atmospheres and then simultaneously at 12 atmospheres for the simultaneous kissing. And then we place a synergy Megatron 3.5 into 32 because the LAD reference was 3.6 and the LMCA was 5.0. We deployed it at 11 atmospheres, keeping about 8 mm in the LMCA for the pot. And this constitutes the second crush of the LCX stent, and so the LCX wire is already out, you can see. The LMCA pot is done with a 5 into 6 balloon. The LMCA reference diameter was 5.0 in the IVUS, and we keep balloon proximal to the carina, and the LAD is posted at 3.5 non-compliant. Subsequently, we do the second recross through a non-proximal strut, preferably a mid strut, and we confirm it on the IVUS as well. So IVUS actually from the LAD as well as on the stent boost, it's a non-proximal cross, and the LAD MSA is quite okay, 8.7. The LCX struts again open a 2 semi-compliant balloon, and we do the second kiss, 3.5 12 in the LAD and 3.5 12 in the LCX. First each sequentially at 18 atmospheres and then simultaneous kissing at 12 atmospheres. And then we do the final part of the LMCA with 5O balloon at 18 atmospheres, ensuring that we are proximal to the carina. The whole procedure took about 80 ml of contrast, good angiographic outcome, and we confirm it on the imaging. So we had on the IVUS pullback, we had a good MSA in the distal lady about 9, in the proximal lady the MSA was about 10, polygon of confluence MSA was about 14, and the LMCA MSA was about 19. On the LCX also pullback, the MSA on the proximal LCX looked about 10, it seemed to have a well-formed carina. So these diameters all actually get into the dimensions that is required for a proximal optimal LMCA 2-stent strategy which has been defined. So this case, IVUS actually helped in each of the steps. It ensured at the final outcome that not only angiographically things look good, it was good, there was good expansion, no malapposition, no distal edge dissection. There was no geographical miss. We had good areas, about 19 in the LMCA, 14 in the polygon of confluence, 10 in the LAD, and 10 in the LCX. And we demonstrated a modified decay crush with IVUS at each steps, almost 6 runs, 2 pre-runs, 1 after each of the rewiring, and 2 post-runs to ensure that there is good apposition and good expansion. So, and this IVUS actually guided at each of the steps, as well as helped us in deciding that we take a Megatron so that it goes up at 3.5 in the LAD and 5.0 in the LMCA. The second case is actually a person who underwent and stenting to the ostial lady, tried to place an precise ostial placing of stent about 10 years back, now came with unstable angina, recurrent rust angina despite medical therapy. ECG showed evidence of ST depression in the lateral leads, and this was the angiographic result. So we find that there's a pure ostial LCX lesion, about 90% lesion, and you have a stent placed in the LAD, and we find some aneurysm in the LAD. So we have a old stent placed precisely, supposedly in the pure ostial place, and with some aneurysm there, and a LCX ostial critical lesion, and an aneurysm in the LAD stented segment. So we wire both the vessels, and then we start having an imaging assessment of what's going on. IVUS was an eye-opener in this case. We clearly see on the IVUS pullback that you have malapposed LAD stents in the aneurysm, that is expected, but you have underexpanded stents in the ostial lady, and the stents, as expected, had actually crossed into the polygon of confluence across the ostium of Cirque. You have struts across the polygon of confluence and the ostium of Cirque into the LMCA. You can see that on the IVUS pullback. So the IVUS shows that the LAD ostial stent is underexpanded. It is going across the polygon of confluence, and there is late acquired stent malapposition in the aneurysmal segment of the LAD. So once we understood what the pathology is, we didn't want to crush the LAD stent. We actually post-dilated the underexpanded LAD stent first with a 3.5 non-compliant balloon, and we have post-dilated the polygon of confluence and the part of the stent in the LMCA with a 4.0 balloon. And once we had post-dilated the stents, we rewired the LCX through the stent struts, opened the stent struts, and then did a kissing balloon with a 3.5 non-compliant balloon in LAD and 3.0 balloon in the LCX. Then we did an IVUS to the LCX. So on the IVUS pullback from the LCX, you can actually see there's a possible calcific nodule in the LCX. There's osteoproximal LCX is about 3.5 diameter. The LMC is about 4.0 diameter. But we seem to have good luminal areas after the lesion bed preparation. So we place a stent now from the proximal LCX to ostial LMCA. A 3.5 24 synergy is placed at 18 atmospheres. And the LMCA part is done with 4.0 balloon at 18 atmospheres. We rewire the LAD through the struts, and the LAD struts are opened with 2.0 balloon and 3.5 non-compliant balloon, and then we do the final kissing balloon with a 3.5 non-compliant balloon in LAD and 3.5 non-compliant balloon in left circumflex. Then we finish up with a final part in the LMCA with a 4.0 non-compliant balloon and 18 atmospheres and do an ostial flare. So this is the final angiographic outcome. And this patient is doing good on follow-up. Final IVUS imaging shows good expansion, about 9.1 in the proximal LAD and about 12 in the polygon of confluence. And in the LCX pullback also shows good expansion and good apposition, almost 8.4 in the proximal LCX and 13 in the LMCA. So this was old, precisely ostially placed stent, which had come back to the LMCA, caused an ostial LCX clinical event, which was actually dealt with a reverse decay miniculot. So the second case actually highlights the use of IVUS in scenarios where you had dealing with an LMCA bifurcation PCI stent failure. In all these scenarios, IVUS is quite handy because the second case, IVUS actually helped in understanding the mechanism of ostial LCX stenosis. The LMCA stent, the LAD stent had already come to the polygon of confluence, and this helped us in deciding how to approach this case and to revise our bifurcation strategy. Instead of crushing, we actually made it almost like a mini culotte. And to conclude all these scenarios, IVUS helps a lot in predominantly LMCA lesions in patients who have renal issues. It helps not only in reducing the contrast, reducing CIN incidence, but also goes a long way in improving long-term outcomes. Thank you.